in this region. And we've all shared from and learned from the things that you're doing. Now, some of you will have heard some of what I'm about to say already, but none of you will have heard some of it. Indeed, nobody would have heard some of it, because I'm actually launching some new elements as well. So it will be worth you staying through to the close in terms of thinking through. So in terms of what I'm going to be covering through, well, I didn't actually go for a photo shoot to the moon. Very helpfully, we had a lunar landscape in Lichfield Cathedral, which is my local town, over the summer. And I couldn't resist, if you're having a theme around small steps, having a small step and a giant leap. Because actually, the sorts of steps that we're taking are in many ways small steps that build on the literary skills that are absolutely key to how library knowledge services act across all sectors. But when we bring them into health, we can ourselves, both through our own services and services we work with, make a huge difference. Now, I'm going to ask all of you to make the very smallest of steps to begin, and that probably includes people on the live stream as well, just in case they feel left out. If you're able to do so, could I ask you please to stand? Thank you. So, if you have a degree in classics, or if you are a native speaker of Greek, could I ask you please to sit down? So we have a few. You are such a highly informed and cultured audience. I knew there would be a few. If you have an A-level or equivalent in either Greek or Latin, GCSE or O-level in either Greek or Latin, just a few. Now look around you. The majority of you are still standing. The people who are sitting down are actually now your guides. They are the highly informed literate few who can actually guide you through the signage that exists in most hospitals. As if you think about it, we have lots of words that are a mixture of Latin and Greek. So we have neurology, radiology, gynecology, and then this particular example, which looks particularly bad actually in here at the moment, I couldn't even stand far enough back to get a decent photograph of it, but it also then includes some wards that are by people's names. So Marjorie Warren and James Mackenzie. I'm sure erudite, but it doesn't actually tell me what sort of ward it is or what it is that we want to do. And if you're thinking about it from a health literacy perspective, if you can't find somewhere, then you are actually going to miss your appointment. You're not necessarily going to arrive in a good state, even if you do find where it is that you're going to be going. And that's what we're going to be thinking about through today. Now sit down. So what do we mean by health literacy? So fundamentally, we're looking at both system and personal aspects. And if you read through the older literature, you'll find that quite often, particularly US literature, makes health literacy sound as though it's all about text and all about a personal responsibility to be able to take control. But it isn't just about the person. It is about the system and how the system enables somebody to understand information. So if somebody doesn't understand, the blame, the fault lies with whoever's communicating. It doesn't lie with the person who's being communicated with. Fundamentally, we have a mixture in terms of health literacy of elements that are to do with access. Can you find it? Can you find it when you need it? And do you know whether it was what you actually wanted? The ability to understand it. So how does this make sense for me in my context? To appraise it. Actually, is this right? Facts matter type things? Who funded it? Those sorts of questions that we ask of all of our different sources. And the ability to use it. So if it tells you, for example, about how frequently to take a medication, do you know what that really means in terms of how often a day, before meals and all the rest of it? So it sounds as though it's a very fundamental skill. You'd imagine that everybody is able to, for example, understand a paracetamol leaflet. But it doesn't necessarily always prove to be the case. So I'm going to share with you two sets of slides. So the first set, many of you in the room will be familiar with, because we're looking at a general view, region by region, in terms of health literacy levels. what you're seeing for the first time today is you're being the first to get a preview of local authority by local authority data. And you'll see that actually, particularly with the southwest, the picture looks completely different when you get down to the locality as opposed to being at a wider level. So at a wider level, looking at the health literacy element, if you just take the words, then 43% of the population cannot understand the information sufficiently well, for example, to give the correct dosage of paracetamol to a child. Not quite the majority, but a significant minority. This is data that's in relation to the 16 to 65 age group, because those are the data sets that exist. It does not mean that magically, as soon as you turn 66, you're going to become very health literate. There's a reasonable hypothesis that actually your health literacy may get worse as you get older. We just don't have the data. So it's a significant issue when we're thinking about it in terms of the elements for the national picture through. And you'll see that actually in the southwest you look pretty good, because actually it's only 38% of people not understanding. So it looks quite good at the moment. We then move through, if you add numbers, so it's not just to do with the text, it's the numbers as well, which could be, for example, to do with the number of times a day you take something, it could be to do with the number of tablets you take, the combinations of different things. Numbers are a very real issue with health information. Now, across the whole of England, we now have a national average of 61% not understanding. So that means the majority of adults do not understand information in terms of their health literacy levels. And again, the southwest doesn't look too bad. So it looks at the moment as though it's 55%. So not too bad at first glance, but actually if we begin to look at the detail, this is where we see that actually across what looked as though it was quite a homogeneous area, these are just some of the examples of the elements at the local authority level. I will give you the full slide link at the end, and you will be able to click through later on so you can play with it. But these are just samples, because I couldn't possibly have fitted all of the detail onto a map of the south. But just in terms of variation, within the southwest you actually have the most health literate local authority across the whole of England, which is Hart in Hampshire. So basically they only have 27.48% of the population who can't understand text. That's pretty good. But then not far away you have Slough, where it's up to 53.99%. So we have significant variation across the region in terms of the words. And then if we come to the words and the text, so if you remember back, this was where we had 55% rather than 61% as being the average across the southwest, which looked pretty good. But again, we've got significant variation, broadly following the same sort of pattern in terms of trends. Again, it's Hart that does fantastically well. So only 46.35% of people can't understand. I say only, that's still nearly half the population, if you're thinking of it in those sorts of terms. By the time you get to Slough, you're actually up to 71.63% of the population that can't understand the information. So significant variation. You're not absolutely up at the top. The lowest health literacy nationally in terms of words and numbers together is Newham, which is at 81.75%. But when you think of that in terms of real people and people's lives, that's a terrifyingly high proportion in terms of people not being able to understand and act on information that's available. So what do we mean by different elements of health literacy? Well, I would expect in this audience that you go back to your literature, and many of you will have seen that actually it's Don Nutbeam back in 2000 who first was publishing different types, different levels of health literacy. And he varies in his language. He sometimes refers to types of health literacy, he sometimes refers to levels of health literacy. So if you're thinking of it in terms of these different types, these different elements, one of them is functional, so that ability to be able to obtain and apply information. Now that's pretty fundamental to many of the information literacy skills that not just ourselves, but our counterparts in other sectors of teaching. We then have interactive, so the ability to extract the relevant information and to be able to apply it to different circumstances. And then finally the critical, so your ability to analyse. So who funded this? What's the bias within it? Is it current? Those sorts of elements through. So our functional and our critical, I would say, are very much the bread and butter of information literacy and critical appraisal. The element that makes health literacy slightly different is that it includes some of the communication skills in terms of the application around the interactive. So if we're thinking about how that works out for individuals, our functional health literacy is very much around things like being able to read appointment letters. As if you actually understand the appointment letter, then you're likely to be able to attend your appointment. If you didn't understand it, then actually it's hardly your fault if you can't actually match your letter to the signage in the hospital, for example, and you can't work out where it is that your x-ray is about to take place. The interactive, so with the ability to balance different sources and your ability to be able to make decisions, some of that is to do with how did you have a conversation with someone, how did you make sure you've asked the right questions, you've been able to act on the information given. And then the critical in terms of the being able to challenge sources, interpret sources, not just take things at face value. Now, it can be, in terms of thinking of it as levels, that people will assume, perhaps slightly naively, that you have certain people who are always at the functional level, some that always have an interactive, some that are always critical. But it doesn't quite work like that. So if we're thinking about individuals and how individuals respond to situations, Trish Greenhalgh, I think, can be said to have written the book, really, in terms of evidence-based practice, how to read a paper, and yet she herself, when she was diagnosed, indicated that despite being a professor herself, the first thing that she did was to type breast cancer into Google. Because she was worried, she was concerned. And for all of us, that point at which actually you are panicking, particularly if you've just had a new diagnosis, your health literacy level will drop. So health literacy is not a fixed thing. It's something that can actually move through. So those are some of the theory elements. I'm then going to share a little bit in terms of my own experience. And I'm sure that many of you will also have experiences in terms of elements through. I'm going to move through slightly. So thinking in terms of personal experience. So one of my experiences is in relation to my eye health. Now, I happen to have a relatively rare condition which affects my eyes. It's sufficiently rare that most opticians will never have seen it. So fairly rare. At the point when I was first observed by an optician, the optician in question panicked. They went into, we need to refer you to A&E immediately and see whether or not we can get something done, because they thought that I might have a brain tumour. It's actually just that I have what's called optic nerve drusen. So I have excess calcium in my optic nerves, which over time expands. So it looks as though the optic nerve is actually pushed out, and it looks as though I've got a brain tumour behind. But actually, so far, there isn't a brain tumour there. But my own response in terms of the literacy elements was, again, I was slightly disconcerted. I was just going for an eye test. I was not expecting to have a referral straight through to A&E. I'd arranged to meet up with my aunt for lunch, you know, it's all those really practical things that happen in one's life in terms of the real life experience. And for me, there's that sense in which I knew that at that stage my own health literacy was quite low. Fortunately, they managed to get through to a triage nurse in the eye clinic who was very sensible and actually asked whether I was in pain, whether I was experiencing dizziness, whether I got blurred vision, all those sorts of very practical things, and ascertained that actually I didn't need that urgent referral. I need a referral, not that urgent a referral. So that was my experience in terms of the low health literacy element with this interaction. What I think was actually quite a health literate response in terms of the practitioners around me was when I went to the eye clinic, I had a review, I received my diagnosis, and then I was asked by the consultant, what is it that you need to tell an optician so that they understand what your diagnosis is? What is it that you need to tell them in terms of what the records are likely to say, and where are the records? So she was actually making sure that in my own words, I could explain what the situation was, rather than having an expectation that I somehow will just regurgitate what it is that she'd already told me. And she was also double checking that I would be confident to have a conversation with an optician, because she didn't particularly want to have people referred in inappropriately. She wanted to make sure that the good conversations were taking place in the community. So just my personal experience, just one health condition, but my own element in terms of actually not just my own low health literacy, but the panic of the optician that I was seeing and my response to that, and then having a much more health literate conversation in terms of the consultant double checking how those elements will go through. So that was my experience of what it felt like. I'm now going to give you an opportunity to experience what you might feel like. And for those of you who have heard me speak before, I promise you this is a completely different exercise from anything I might have done previously. So don't think that you're just going to be able to wing this one. So, for those on the screen as well, in terms of watching the live stream, I think everybody can take part in this test. If you could take a piece of paper. Okay. And you're going to have 30 seconds to work out a code. Okay, and it's very easy. It's the sort of thing I'm sure you did at school. You find it absolutely very straightforward. No trouble at all, no pressure. But you are being tested, and do not compare with anybody else. Okay, are you ready? And starting now. So you're probably about a third of the way through by now, I should imagine. It's very easy, isn't it? It's very straightforward. You see, you probably did do it at school. Oh, and if anybody's finished, if you could just fold your arms so I can just see that you've finished, that would be great. Just to give some sense of, I don't know, what it is that's actually going on in the room. And time's up. That was lovely, wasn't it? Okay, so what shape was being described? A circle, very good. Now, who was guessing? Okay, that's fine. And look, there will be that element in terms of if you don't understand something, you might just guess, or half guess. There will be some people who do actually know just like that. One of my brothers is an actuary, and he would have just known like that. Very annoyingly. But it's just one of those things. We have different skills, different elements through in terms of our experiences. And how it makes you feel. For some people, actually, if you could do it, that's probably fine. You might have had a bit of a question as to why on earth is this woman making me do this? But you probably felt okay about it. For some people, actually, there will be a frustration in terms of thinking, I'm sure I used to be able to do this when I was at school. And why is she talking over me? And I'm sure she's doing that deliberately, and she was. Because if you think about when you have nurses giving out forms to people in terms of surveys, and sadly it is particularly nurses, they do talk over people. They give them the form they're supposed to fill out, and they talk at them at the same time. And how can they fill in the form and be talked at the same time? It just doesn't quite work. There will be some people actually felt quite distressed by it, and some people may have felt actually angry. That sense actually, why are we doing this? Why is it an exercise? And it is purely an exercise, and the point of the exercise is to do with sometimes you don't understand. And how we respond emotionally to not understanding will vary according to who we are, where we are, things like whether we've just recently been diagnosed with a condition. Those have a significant impact in terms of elements through. So the serious implications are things like misunderstandings. So if your emotional resistance has gone up, then actually you're not going to understand the rest of the conversation. Some of it could be poor decisions, because if you didn't understand the basic premise, you're not necessarily going to make a good decision. It can exacerbate inequalities, because there will be some people who find it easier to understand than others, and if you treat everybody the same, then actually that's not necessarily meeting the needs of people in front of you. You can get things like inappropriate use of medication. I remember when I was at Macmillan, we had services in South Wales where literally the medications were colour-coded for day and night. so that, and a mark in terms of this is 3 elements down and this is night and this is day, to make sure that people were able to understand which medications they were taking at different points in time. But unless you provide the support to people according to their particular needs, you might misjudge who actually needs that sort of support. You get ineffective access to health services. There's people either go to A&E unnecessarily, or else they don't find their appointment because the letter and the language used in the letter they were sent did not match the signage in the hospital that they were visiting. So you don't get appropriate access. And fundamentally you get poor health outcomes. And this is not just to do with when people are diagnosed with long-term conditions. We are living in a society where all of us are likely to live longer, where we're likely to have multiple conditions, and the NHS is not going to get any bigger. So we are all going to have to self-manage much more. And unless we understand how it is that we look after ourselves, it's public health information, things like diet information, nutrition information, we're not going to be in a position where we can actually make sure that we make the most of our lives and our healthy outcomes. So how can we help? Now I'm going to start with some of the things which are specifically around health literacy, but I'm also going to broaden into some of the elements around information literacy and digital literacy, because with some of your colleagues, those are the elements that you'll need to use in terms of hooks to get people engaged. So in terms of how it is that we might get involved, well, I'm hoping that many of you will have already used the how-to guide on the Health Education England website. So this was developed jointly between Health Education England, Community Health and Learning Foundation, Public Health England and NHS England. Its resource actually is partly about how it is you do basic techniques, but also it's how it links out to different resources available to you. So it gives you things like core definitions, which definitions you might choose to use, how it is that you might apply health literacy in terms of general communication, how it is you might use it when you're speaking, how it is you might use it in terms of written style, so how it is you present information on a page, the design, the print, pictures, photographs, and those sorts of things. But it also includes things like business case, because actually sometimes these things require money. So a template for what it is that you might put in terms of a business case. Case studies, they happen to be predominantly case studies from the East Midlands, because that's where a lot of the test work was done. Training materials, and therefore resources you can begin to adapt, begin to use in terms of elements through. And in particular, there are 2 of the techniques which are covered both within this guide and also within some e-learning that we're currently developing jointly with NHS Education for Scotland to be available at the beginning of next year. So in terms of techniques, one of the things that you can teach yourself and help colleagues to work with, whether they're colleagues within library and knowledge services or other colleagues, is to use a teach-back technique. So this is where actually it's the tell me. So I don't know if you remember in my story, I mentioned with my personal story that the consultant in the eye clinic asked me how I would tell my optician about my experience and my diagnosis. So that was actually an example of teach back. So what she was doing was she was actually making sure I'd understood. So you've got 4 steps effectively. The first is that actually whoever is doing the communication has to take responsibility. So it may be, I'm not sure whether you can read my handwriting, or I'm not sure whether I expressed that clearly, or something that makes it clear that you are taking responsibility for it. There's then the tell me. One of the examples I quite often use is how would you tell this to your children, or how would you tell your employer, or those sorts of examples. There is something about how you would ask the person how they would tell somebody else that gives you an insight in terms of what they've understood. If they don't understand, then it means you've got that opportunity to re-explain and then continue until you're both happy. In practice, the loop doesn't often need to go round very many times, provided you've got reasonably decent communication to begin with. And part of the persuasion of colleagues is to do with how it is that it can save them time in the longer term. So if you're thinking about, for example, research that was published by the Royal Society of GPs, half of what is undertaken in a GP consultation is forgotten, and of the half that's remembered, half is misunderstood. Now, if you can increase the amount that's understood, then that has to be a good use of some of the time within that consultation, as opposed to assuming that everything has to be absolutely fresh. So your teach-back technique, and so there are much more by way of guidelines and links through in terms of resources that you can use, including the Health Literacy Place, which is the Anxious Education for Scotland resource, within the toolkit. Quite often teach-back is used alongside chunk and check. So chunk and check is basically where you take communication into very short sections. Of course, I'm speaking with you in a very long series of different elements through. It's not how you would do a communication if you're trying to do a chunk and check or teach back, because of the nature of the group interaction. But if you're one-on-one with somebody, I suspect in many of the sessions you're already doing, you're actually going through in terms of whether or not people know where it is to sign in, whether they know which databases they're using, whether they've got some sense in terms of how it is that they're constructed their search, those sorts of things. You're probably on a day-to-day doing a chunk and check. But it's a way of making sure that a small amount of information is understood and then can build to the next stage. And that's not just in terms of spoken information. It can also apply in terms of written information. Because again, having information that's in shorter sections that build mean they're much more likely to be understood by a broader audience than if you have a long section of text where people have to think, oh, actually, what's the key point of that paragraph? Oh, actually, where was the verb? You know, I'm sure that people get to that stage sometimes when they're reading through. So keeping the sentences short, using lists where you can do, if it's appropriate to do so. Using active verbs, so take the tablet 3 times a day rather than using passive verbs. Avoid writing in the third person and using words that are appropriate to the reader. And that takes some nuance, some understanding of exactly what your particular context is. So fundamentally, nothing beats user testing and actually spending time either yourselves or knowing that somebody else has done the user testing. You don't have to create this content, but I would discourage you from creating content if it already exists. It's actually about knowing that whatever content you're using or your colleagues are using has already been tested. You can also make sure that your services are health literacy friendly. So if you're thinking about your own library knowledge service, now, depending on your estates within your hospital, the chances are you're not going to be able to make overnight changes to those dreadful, dreadful signs around the building itself, but you can make some differences within the service that you're running yourselves. So there's something about the written communication. So do you actually have a style guide, a policy, a way of working in terms of actually what it is that you do in terms of the written communication that you have yourselves? Do you make sure that anything that you're using, particularly if it's patient and public information that you're signposting or that you have copies of within the library, that has been user tested? So those sorts of very practical things. There's also spoken communication. When you answer the phone, do you make it clear that it's the library knowledge service? I'm sure you do, but there's something about that very practical element through. Do you also make it clear that you can actually ask for help? Whether that's in terms of badges that people are wearing, or signs, or how it is that you speak to people, particularly how people on the front desk are speaking, to make sure that there are those opportunities in terms of getting further support when you need to. Also, do you think about using things like the chunk and check and the teach back? You're probably doing that intuitively, particularly in your one-on-one training sessions. But thinking about it a bit more consciously might help you to think about how it is you might guide your colleagues to be able to do it too. And then there's the stock. So some of you will be holding patient information, some of you will be signposting it. But actually, have you thought about it in terms of the accessible information standard to make sure you've got materials that are available in a wide range of different formats? And have you taken advantage of the fact that actually we now have digital copies available of evidence to patients so that we can provide those under our copyright licensing agreement? So it's how it is we actually make sure that information is available in the right format. And then the signage. Well, we criticised the signage in terms of the hospital itself, didn't we, earlier on? And it's one within my own region. It's not one of yours, I hasten to add, in terms of the example I gave you earlier. But actually, do you review your own signage? Have you ever had any blind user testing, as it were, getting people going through, could they find where they were expecting to find things when they went through your own library service? So getting users to test your own library signage. making sure that actually your own staff have taken advantage of the health literacy awareness training that's on offer at the moment, in terms of the rollout that we're doing to library knowledge services staff, and that actually you signpost or you provide training in terms of what's available to colleagues elsewhere. And then lastly, policies. Now some of this will be to do with the main trust policy. You won't necessarily have a health literacy policy, but you can make sure that the policies are health literacy friendly in terms of the elements through. So those are some things now. And as I've already alluded to, many of the NHS Library Knowledge Services will have already had your training in terms of your awareness training in terms of health literacy awareness. Do take advantage of the opportunities through. From early next year, we're going to have a suite of different levels of tools. So there's some elements in terms of a full day, a 1 hour, a 15-minute, and e-learning options, so that we can make sure that we can signpost to different elements according to what's appropriate for different audiences. And it's how it is that we're actually able to use those effectively. So health literacy is definitely a priority to the end of 2020, but it's likely to be integrated into wider elements in terms of our next knowledge for healthcare. So I alluded earlier to the fact that this is not just about health literacy in terms of our roles, but it's perhaps some of the elements that some of our colleagues in other sectors would see as being the other literacy elements. So if we're bringing the literacies together, information literacy, I would argue, is the absolute core bread and butter of library and knowledge service practitioners across sectors. The model that I've put on here is actually one that I'm sharing with permission from the Cambridge Information Literacy Network. They looked at various different models, and they felt that fundamentally there are 4 different areas in terms of competences and skills that are needed around information literacy, one of which is resource discovery, so being able to find it, being able to find it clearly and make sure it's the right thing that you found. Then there's the critical assessment, the ability to manage information. So thinking about students, you're thinking about trainees, etc. People need to be able to manage their own information as well as you managing information. And then there's the creation and communication of content. So those they saw as being the 4 fundamental areas. And then on the digital literacy aspects of things, we have 6 domains that colleagues within HEE have identified as being valuable in terms of how it is that we work on digital literacy. And these are building on work from GISC. So it's partly digital identity, communication again, teaching and learning, information, creation and technical proficiency. So if we think about how those all come together, I would argue that actually information literacy, that core thing that we might need to talk about to persuade others that of course this is the role of the Library Knowledge Service, is fundamental across all of these different areas. The areas where there may be a slight exception is to do with the interactive literacy. That communication skill aspect is a slight extension for some library knowledge services in terms of health literacy. And if you're looking at the digital literacy skills, then some of the elements about that digital identity, that being safe online, and the technical proficiency, some of those are perhaps a little bit more borderline in terms of the core role of the library knowledge service. But nobody could argue that the other elements are not absolutely the areas where you have expertise, where you have the opportunity to be able to shape what it is that an organisation is doing. So if we think about things like the TOEFL review, actually the future depends on digital literacy and e-health literacy. So we've talked about health literacy predominantly in terms of written and spoken communication, but more and more it is going to be the e-health literacy that is significant for the future. I've already alluded to an ageing population, the fact the NHS is not going to get any bigger. We are getting more and more sophisticated apps and other tools in terms of people being expected to self-manage, but unless they can do that effectively, then they're not going to be able to make a difference in terms of their health. So we do need to make sure that we're tied in, and we do need to make sure that actually that core information literacy becomes an enabler of the future. So TOEFL makes recommendations in terms of the citizens and the patient. And as I'm sure you're all aware, with the TOEFL review, Eric Topol himself volunteered his time to lead this internationally groundbreaking element through. So he had absolutely no vested interest in terms of elements through this delivery. when you look at the recommendations, you will see that actually they're all in different sections. And the overarching section is the review board. And the ones that are to do with the citizen and the patient are predominantly from the review board. So they're not just to do with genomics or robotics, they are to do with the whole of health. So we have elements about education about genomics. It's been one of the key areas in terms of digital health literacy. Work with patient care organisations to develop education, but also needs-based targeted education and support. And I think that is in many ways where library knowledge services can come in terms of supporting colleagues to be able to do their supporting through at an individual level. So our next steps will be very much around how it is that we incorporate health literacy with digital and information literacy in the next iteration of knowledge for healthcare. So this is taking us in the next 5 years. We've had the first 5 years, moving into the middle years, as it were, in terms of the 15-year framework. And as we develop those through, in terms of the elements of digital literacy, information literacy, and health literacy, it is through those that we can begin to make a difference nationally and locally. So I'm going to leave you with the link that I mentioned earlier on in terms of the data and how it is that we actually work through. And then I'll take any questions as well. But do think day to day about how it is that you are already making a difference. As I mentioned at the beginning, within this region you've done a phenomenal amount in terms of the broader patient information spectrum. And this is just one dimension of activity you're already undertaking. And perhaps sometimes it's a different label to information literacy, which is the core of your work. Thank you.
We have 10 minutes of questions. So if there are any questions for Ruth, stick your hand up. I'll start with just question there.
The amount of information online can be very overwhelming, especially in the area of health literacy. Is anything being done in terms of how we as professionals disseminate that?
Okay, so I'm going to try and paraphrase the question back.
Okay.
So your question is to do with the sheer overwhelming nature of information online, and whether there's anything that's being done to make it easier for people to work out and to access the high quality information within that? Is that a fair paraphrase back? Information online is it's a fantastic resource, but it's also a terrifying resource because of the sheer volume. There have been various attempts in terms of looking at different standard mechanisms, in terms of different appraisal techniques to help people through. Some of that, I think, in terms of our core tools around things like Discern as a tool for patient information still applies. There are links through from NHS UK, what used to be called NHS Choices, to trusted partners in terms of information. So it's worth double checking in terms of elements through with that. They use, in terms of their priorities, the services that have previously gone through the information standard, but also those that they have partnerships with and they have some reliability of trusting through. Nothing quite beats looking actually at the sites themselves in terms of what the original sources are, but there isn't necessarily always time. I mentioned earlier that I used to work for Macmillan. Macmillan has its own appraisal. If you go to the resources directory on the Macmillan Cancer Support website, there is an annual review of all of the printed leaflets that are identified in the UK, and those are then assessed using Discern, and they're assessed using basic information literacy in terms of information level tools as well. So there are various tools out there in terms of elements through. Do go back and look at the section in terms of the ideas then also on the Knowledge of Healthcare blog page, because again some of that is linking through and we're just reviewing and updating some of that section as well. So I hope that's helpful.
Yes, it's very challenging to get this on our remit really, so as I mentioned before, we all try to do little bits, but it's only ever recognised as little bits, and where we are as a whole, the trust doesn't look at us and say, right, you're taking on board health literacy, you're going to really make sure our patients understand what we're telling them. Is there anything being done at a more national level to raise the profile of library knowledge services with regard to health literacy?
So the question was to do with whether, in a very crowded space potentially, depending on your NHS trust, whether we're doing anything nationally to support local prioritisation in terms of local services, library knowledge services, owning the space around health literacy. Is that a fair clarifying? It's a very, very timely question with the refresh of knowledge for healthcare. We're certainly in conversations with CILIP and others at the moment in terms of how it is that we might be able to, should we say, own the space, because we feel that it is very much drawing upon those core information literacy skills, and that we can probably do this work much more effectively than many others can, because it is drawing on that core skill framework. So we are likely to have some elements through in terms of new knowledge for healthcare. We are certainly looking at it in terms of partnerships with our next iteration of our partnerships with Libraries Connected. So Libraries Connected used to be Society of Chief Librarians and provide the support in terms of the public library sector. So how it is that we might be an advisory, an expert source to them in terms of partnerships as well. So I think it's a watch this space, because I absolutely appreciate there are some things where you need a national push as well as being able to do things locally to make things happen.
Thank you.
We've talked about different ways of accrediting the information and getting things onto a list of sort of good quality sites for information. And now that the information standard has become defunct, is there a way in which it might be a useful vehicle for a national collaboration between the health services in Wales, Northern Ireland, NHS Education for Scotland and Keys to come up with their own accreditation framework and maybe lead the conversation on that?
That's a nice question. So the question was in relation to, with the information standard, which is the NHS England-led initiative in terms of activity, basically changing, and I'll come back to that, whether there are opportunities in terms of England, Wales, Scotland and Northern Ireland coming together. Is that a fair paraphrase in terms of elements 3? So, the information standard has had a long gestation and perhaps a slightly mixed history. So it originally started with work by Neil Gray and Angela Coulter in particular to develop a mechanism whereby you could actually look at a resource and see whether it was high quality. Initially it was about a review of process, and the organisation signing up for the process and being assessed on that. It was then expanded so that it also included spot checking and was funding to have the spot check and a review process, which was done through NHS England. Sadly, NHS England is no longer in a position in terms of its remit, because its remit has been refined over time, to be an assessor, and it couldn't find another body to pick up the assessment process. So organisations that have the standard for existing content up to July 2022 are still able to use the standard, but actually any new pieces or any revised content they produce no longer has the information standard logo on it. There is discussion at the moment which the Patient Information Forum is convening with various different national charities to see whether they can develop some sort of mechanism for effectively a peer review mechanism through, to see whether or not there's an opportunity to improve the content that way, because they are key producers in terms of content. I think the question is a very timely question again in terms of thinking about our relationships through with other nations, because actually we've got what we call the Five Nations meeting this week. It sounds very grand, doesn't it? It's Five Nations because it includes the Republic of Ireland, but basically it's the library leads for the NHS, or for the equivalent of the NHS in each of those Five Nations. I'm actually meeting in Birmingham over the next couple of days. So it's an interesting timing through. I suspect that actually it will be the voluntary sector-led element through, because they're the main producers, but there is something about making sure that we tie in with particularly people like NHS X and NHS Digital, in terms of how it is that they are appraising content, because it's what's linked through to NHS UK and other resources that has a key element through. So it's not just the production, it's the who, how you surface it, what your discovery mechanism is to get to it.
Time for one final question.
So, it sounds really awful, but in our trust, things like teach back, it's talked about the education
okay, I'm paraphrasing. So, question in relation to role, where you already have education teams that are doing things like teach back, and you have patient information leads who are working in terms of patient information leaflets, etc., within a trust. I think that the opportunities vary, and it may well be that actually the role is partly to do with partnership with those teams in terms of what it is that you can offer to extend their work, because I'm sure they're not actually meeting everybody in terms of reaching the need. There's also what you might be able to do in terms of partnerships out into the community as well. So whether that's working with public libraries and others in terms of getting people in terms of making sure that there are opportunities for them to have high quality information through the organisation. So there are always different ways. Health literacy, I think, is valuable partly because it gives a language that our colleagues can understand. It begins to give it also a measure, because we now know the extent to which it's an issue in different localities. So the opportunities will vary according to the trust, but I think that there is something about framing it in terms of how it is to contribute to existing agendas, how it is you might be able to create new partnerships, and actually create different ways of working, because you would never be able to do everything, but you might be able to contribute in ways that actually make it better for the organisation.
Thank you, Ruth.